that, I'm going to turn the microphone over to Sandy McKenzie, who is the Chief Operating Officer and who has not had an easy job during this time. Turn the microphone over to her to introduce Dr. Lee Connor. Sandy, before we get started, thank you for everything you have done, as well as all the medical providers within our community, both with Hamilton and otherwise. Thank you for the time, energy, and love that you provided to our community. And so with that, I'll turn it over to you to introduce our speaker.
Thank you. Thank you, Amanda, and thank you to everyone out there in the community. This has certainly been a community-wide support that we've had here, and we do appreciate everyone's giving to us over these last several months. It takes a village, and in this case, it has taken a village as we've worked through this within our community. So what I'd like to do, though, is introduce you to Dr. Lee Connor. As Amanda said, we're very fortunate that we have an infectious disease physician, and his timing of coming to join us was certainly had some, I would say, some intervention from above, because to have him here as we've gone through this process and dealing with the pandemic has certainly been a huge support and help to our health system. I can't imagine where we would be if we had not had his knowledge and expertise to help guide us. But Dr. Connor just joined us in August of last year, and as the infectious disease, and so I will let him tell you just a little bit about himself, his background, his training and stuff. So, but I'm going to turn it over to him.
Good afternoon, everyone. Thanks for having me. I'm originally from Florida. Always loved being in the South. I went to the University of Florida for my undergrad, then down to Miami for medical school, and then I've been all over the place, up to North Carolina at Wake Forest to do my internal medicine residency training, and then always loved infectious diseases from the get-go, and so I knew that was not going to be my last step, and so I ended up going to Washington University in St. Louis, Missouri, to do an extra couple of years in specialized training in infectious diseases, and then always wanted to kind of get back closer to home, but stay in the mountains, love to hike and do some more outdoorsy stuff, and people might think I'm crazy, but I got a little sick of the beach, living there for 26 years, so that's what brought me here. I got a little bit of family in Chattanooga, and so this seemed like a very good fit for me. And what a year it's been at Hamilton with the pandemic. So in terms of this current pandemic, just brief overview, as probably most people are aware of, we're talking about this novel coronavirus that first emerged back in the winter of 2019 in China, probably out of the wet markets, probably related to bats, and then just kind of jumped over in that close setting. And so we probably had a few cases in the wintertime, but probably didn't pick up on it until about January, February, and that's when we really started hitting or seeing those numbers kind of uptick and the diagnostic tests starting to mature and allowing us to identify a lot of cases that were somewhat mysterious to us, is kind of akin to the HIV days when no one had it, or people had a very poor understanding of how that disease was progressing and developing in the communities. So a lot of parallels there. Early on, just to give you some history of what we've been doing here, is we had a lot of medical staff discussions with the providers early on about how this could potentially be a pandemic and how serious we needed to take this. We were starting to see the reports out of Italy, and that really prompted us to take a lot of action. And so we had our COVID-19 task force formulated shortly thereafter, especially when we started to see some cases uptick. And that was incredibly helpful to get everybody in the same room to really get us on the same page, have a common goal, and that's really to prepare the hospital as much as possible for that potential surge. And luckily, we didn't get hit with a huge surge as predicted. We were pretty fortunate, unlike other places. But it was a fantastic group that was able to procure a lot of the safety equipment and the protective equipment we needed for our providers, our frontline workers. A lot of support from the community at large, lots of donations, and how to handle all of that. It was just fantastic. So that's been sort of our process, and things have been slowly starting to open up. here, starting to do more, other diseases are out there, and we really need to take care of those folks as well. So it's been a careful balance between managing the current pandemic and treating the usual infections and other diseases that, do run in our community, and not neglecting those folks. So that's been our careful balance here today. We have been seeing an increase. Some of the states like Tennessee, Georgia have, some of these early adopters to opening up early have seen an increase in cases, which is not unexpected. People are starting to commingle a little bit more and, let down their guard a little bit with social distancing. A lot of our population has not seen this virus yet, and so there is a good pool of potential hosts, which we really try to minimize with some of those interventions. So despite being reopened, I would like to take this opportunity to talk a little bit more about continuing social distancing, continue the good hygiene practices that we've been emphasizing, because this virus is in our community. We are seeing more and more cases each day, and this is leading to more and more hospitalizations and utilization and all the things we don't want. So washing our hands, being vigilant about that. If you're sick, stay at home, wearing masks out in public to help prevent the spread, because as we've come to find out, and this has been a huge moving target in this field, is, most people are asymptomatic or have very mild disease. We're probably in the 80 to 90% of folks. So, and those are the big spreaders. You don't know you have it, and you come into contact with all these people, go to the grocery store. So, there's a huge opportunity, and this virus is highly infectious. Without any preventative measures, we're talking about one case can propagate 3 to 5 cases. And with good measures, we try to get that number down to less than 1, so that one person infects less people. And that's really what aborts a lot of these pandemics. So trying to keep up with all those good measures from the CDC and staying apart, wearing masks, hygiene, just really trying to emphasize all of that. In terms of medical care here at Hamilton, we've had a lot of support from the government in terms of ventilators and other supplies that we need, anything we needed. We're also doing a lot of medication management. We've got remdesivir from Gilead that was procured by the government, and so we've been allotted a certain amount of that, a pretty decent amount, which is excellent. So we've been doing that for our folks, trying to get that on board early on so that they do not progress to respiratory failure and going onto a ventilator or needing, ICU care. Hopefully, early adoption of that will hopefully save folks from that outcome. And so we've been doing that. We've been involved in a Mayo Clinic study about convalescent serum, so antibodies to the coronavirus. So we've been doing that. So we've been sort of on top of all of the cutting edge treatments. I work in very close proximity with the ICU care, with ICU doctors, and so we've been all putting our heads together, trying to get what's best for the community in terms of treatment. And so we also have a lot of contingency plans on, where we would house people for any surges, anything like that. So we do have the groundwork and plan B, C, all the way down to Z if we need to. So a lot of that came out of the task force. So that's sort of where we are now in the current climate. So hopefully, we're treating people as best we can right now, trying to prevent infections. Ideally, looking forward, hopefully we'll have a vaccine of some kind, and that will really try to get up the herd immunity so that if the virus is in the community, it really can't propagate itself. And so vaccinating a lot of folks, once that becomes available, I think that's really going to be our way out. So we just have to wait, unfortunately, because we really need to study that and make sure that clinically it's something that's safe and effective. So, and that we can't really speed that up. So I foresee that to be, probably a year from now at the earliest. So this has been tough for businesses everywhere. That was just our struggle. I know, all the community members and businesses around here have had, difficult times and having their workers sick and trying to protect them as well. So it's been very difficult and challenging for everyone else. And that's sort of our story so far and kind of where we're at. And I would be more than happy to open it up for any questions or anything else.
Dr. Connor, if it's okay, I'll go through a few questions that we've received and maybe get a couple of clarifications on things that you said. You said a couple of things. One was talking about the herd immunity. If you don't mind, I know that folks have heard that here and there. If you don't mind, one, explaining that. And then you also mentioned that it could be a year from now before we have that. I know that it's very difficult probably for you to predict what the landscape looks like between now and a year from now when that might occur. But if you can talk a little bit about that, and then I've got 3 or 4 other questions for you if you don't mind.
Yeah, of course. So yeah, herd immunity is just the amount of people in a certain population that are immune to a certain pathogen. So we can kind of think about it like measles. We all get vaccinated against that when we're 1 year of life, and we don't see a lot of measles cases. And when we do, it spikes very briefly and then goes away. And that's mostly due to the herd immunity. Ideally, 100% of the population would be immune to that. And we really don't see that virus propagate. But when there are communities that don't have that herd immunity, where people are not getting vaccinated, there are a lot of folks in that community that can be susceptible to that pathogen. And so we see that can flare up in certain spots. So ideally, you try to get the herd immunity up to 80 to 90% of individuals being vaccinated. You can't get 100% of them. Some chronic diseases, you can't give vaccines to. But you try to get that high enough so that if a pathogen does get introduced into a population, that it can only infect maybe 1 or 2 before it basically burns itself out, and there's not enough susceptible hosts for that pathogen to infect, and then it just goes away. In terms of the vaccine, there are a lot of companies working on vaccines, so I think if you play the numbers, there'll probably be several that get it right and have a vaccine that's not only very safe, but also very effective. And so there's a couple modalities that they're going down and different sort of vectors that they use to make these vaccines and try to make them as safe as possible and efficacious as possible. So I think since there's so many people working on it and there's so much support from the government, we'll be able to have something in the pipeline pretty quickly, and then ramping up manufacturing. That's something that could be sped up. The safety design of the trials and all that, and then you really can't try to purposely infect people with this disease to test a vaccine. That's it wouldn't be very ethical. So we really have to be safe and judicious about that. And then once it comes online, really ramp up manufacturing so that we can get that into the hands of our community members, our primary care doctors, all of them, to really get the herd immunity boosted up. So that's sort of the whole. I think that's our way out of all of this.
Thank you, Dr. Connor. A few questions that we received. How many beds are open and ready for COVID in Dalton, specifically talking about Hamilton Healthcare System, Hamilton Medical Center?
Well, all of the beds, could be utilized if we needed to. We do have certain wings of the hospital that we've made negative pressure, certain parts of the ICU that we've made as sort of a special COVID-19 unit. But this is mostly just to sort of isolate the cases that we do have into a central location, so that the nursing staff, all the other staff, can all be well trained on how to protect themselves in that environment. Everyone has that training, but those folks have additional training, additional experience, and so that we try to cordon them off into their own unit. But we have other units that we can open up and kind of roll that out as things progress, and kind of eat into some of the other hospital beds that have been used for just general hospitalized patients that we typically see before all of this. So we don't have a certain bed count or anything, but we do have contingency plans for when we do fill up certain wings that have been designated to kind of move into a different area, and then just kind of keep moving down the line.
Right. Next question. How many COVID patients, and I don't know if you can answer this, but how many COVID patients month over month have we had? And I'm going to say here in our area, you may only be able to speak to what you know that Hamilton serves, maybe in Whitfield County or other areas, the footprint of Hamilton. So please answer it best you can based upon the information you have.
think, back in sort of when this all first started, we had a few people trickling in, and then it started as things were peaking, sort of a little bit after New York was peaking, sort of the March, April time. We did have a pretty decent amount of cases. We never had to go to Plan B or C or anything like that, but we did end up utilizing a lot of our COVID-19 units. And then we saw that sort of die out a little bit with good social distancing in the community and people being very vigilant at home and really heeding those orders. And then over the last couple of weeks, we have kind of seen an uptick in our utilization of our COVID-19 units. So that kind of coincides with things opening up, things being a little bit more lax. I can't speak to a number as it changes every day, but I think in the last few weeks we have seen a significant amount of COVID-19 patients seeking care in our emergency department, and then a proportion of those ended up being hospitalized for supplemental oxygen and some of the therapies I outlined earlier.
Okay, thank you, Dr. Connor. Next question, and then I know we've got some folks that have their hands raised on the call, so we'll get to them. Next question that we had received is the growth of COVID here versus what is being seen in a city bigger than our size, but certainly close to us, which is Chattanooga.
Yeah, I think Chattanooga and Dalton have both experienced a decent amount of COVID-19 patients. I know Chattanooga and Hamilton County have been seeing a lot of increase there. Also talking about Tennessee and things there too, is Memphis has started to talk about closing that city back down because they have seen a lot of uptick in cases. And then with our climate right now, with the protesting and everything, it is an opportune time for the virus to spread with people being so close together. So I think there's been a lot of, maybe some laxity, some reopening orders, and some other things that have happened recently that have made conditions more ideal for spread. But I think looking at Chattanooga and us, we're both seeing a decent amount of cases continuing, and so that is a little worrisome, and something we're monitoring day to day.
Thank you, sir.
Can you to me?
We can,
Hello?
Archana. Go ahead, Archana.
Yeah, I have a question that people in town, wherever we go, and most of the time we see on TV also that people are not practicing the safety, taking the safety precautions. They're not wearing the mask. That's the least everybody can do. What's gonna be? Everybody's projecting big number of infections coming up.
Yeah,
So
I think that's been very challenging with reopening and balancing the economic cost to this. I totally agree. Our community should try to wear masks and still maintain some of that social distancing and hand hygiene and being very vigilant as the CDC's outlined for us. Those are the best ways we can help protect ourselves and our community from spreading this virus. And I just hope that people will start to heed some of those warnings. This virus, I think people have gotten a little lax about. We saw the spread kind of decrease temporarily, and maybe that was kind of a false sense of security. And now we're seeing some of the repercussions of that. But I would totally agree with you. I see the same thing. People aren't wearing masks out in public, and we should probably treat it as a bigger deal than we already do.
One more thing. My nephew is a virologist at Stanford, and he's directly involved with this COVID-19. And we were talking, and the fact is that even if the younger people don't die, or the death rate is low with this virus for them, but they recover, but the lasting effects are there, the scarring in the lungs or the kidney function or liver function or inflammation of the vessels, blood vessels, does leave some impact that can hurt them later on. And anybody is talking about them or letting them know.
Yeah, there's still a lot to understand as we go forward, and understanding this virus and the long-term repercussions. We're still managing the initial phase, but yeah, it'll be interesting to see, what are some of the long-term, poor outcomes that we see in folks that have recovered from this virus. I've definitely seen my share here of folks getting very ill in the ICU with kidney failure, liver dysfunction, clotting dysfunction, and the damage to the lungs is quite impressive. It's something that I haven't really seen in any other sort of disease process. And the long-term complications of that is yet to be seen, but the scarring, like you said, how is the lung function going to be down the road, decades from now? Those are very good questions.
Thanks.
Thank you, Dr. Connor. Thank you, Archana. One of the questions that I've got, Dr. Connor, for you is, over the last 30 years, do you think medical schools, specifically those that are training our infectious disease physicians, are they year after year training and preparing for something like a pandemic, or for the just in case it happened that year? Or obviously, to some degree, this catches everybody as a surprise to some degree, but is it something that each year they're preparing our physicians that are graduating and coming out of school specifically with this particular training to take on something like this?
Yeah, I think so. In infectious disease, we tend to be a lot of the educators for some of these, for medical schools, residents, fellows. So we do like to take the opportunity to teach as much as we can. I think probably in the last couple decades after the HIV epidemic, we've probably shied away from a lot of how to manage a pandemic or an emerging infectious pathogen, probably to the general medical community, and have kind of fixated on sort of more the bread and butter aspects of it. But in infectious disease fellowship training, it's definitely a good aspect of your training, and we've seen that a couple of times. Fortunately, it never made it over here, but SARS, MERS, Ebola, those things are talked about frequently in the ID communities, and so we do talk a lot about managing that protective equipment, and then thinking about where the next sort of pandemic will be now that there's so much more interaction between people. The world is more cosmopolitan, and so we do get that. Like you alluded to in the beginning, there aren't a ton of infectious disease providers in the country, so our expertise is there. It's just it's not present in a lot of communities. But in the big, in academics, we do try to make our presence known, because teaching in ID is a joy of mine, and it's shared with a lot of colleagues of mine. So, and then I look forward to teaching the medical residents when they get here about some of this, good infectious disease practices during pandemics, and while we're teaching them about bread and butter infectious diseases.
And Dr. Connor, while folks are thinking of what questions they might have, would either you or Sandy address the medical residents that you're referring to, and when that program begins, just as a reminder? And then we've got some folks that have got their hands raised, and we'll go to them next.
Yeah, these are brand new doctors straight out of medical school who kind of followed the same path that I did and fell in love with internal medicine. And so they'll be here. Internal medicine is basically just a very general practice where you get to touch on most specialties. So you get a little bit of each. So you get cardiology, infectious disease, endocrine, pulmonology, critical care medicine. So you get sort of a jack of all trades sort of training. And then they will be starting in July, and I think probably on service seeing patients on July 9th or so, and I'll have one with me then. And so they'll kind of see what I do, and I'll be able to teach them kind of how I practice medicine and what to think about from an infectious disease point of view. And then we'll be able to work together for the next 3 years of their training, and they'll be rotating through the different specialties, getting people's different approaches to how to best practice the art of medicine. And then with the goal of them sticking around and having excellent training and taking care of our community. So that ultimately we all want to train them extremely well so that, if I get sick, they can take care of me.
Absolutely. Thank you, Dr. Connor. We'll go to Jonathan Barlow. Jonathan, do you have a question?
Yes, Dr. Connor, what numbers and statistics should we be focusing on during this in our area, and when should we be alarmed statistically?
Yeah, I think it's hard to put a number on it. The cases day to day, they're of interest, but the rate that increase is happening, I think, basically the slope of that curve is really what I think the most interesting and telling part is like how many of these new cases day to day are happening. So that trend over time, I think, will be important. I know a lot of people have talked about like maybe the second surge is because of diagnostic testing and that people are able to get more and more testing is more and more available. I really think that's trying to minimize the situation. Testing has been pretty good for a couple of months now. People who have wanted a test and have been symptomatic have been tested. We've been able to test, folks at our institution, and we have never run out of tests. So I think some people may be trying to minimize things by saying this could all be, just because testing has increased. But I think these are true cases, and I think looking at the amount hospitalized can be helpful, though those numbers can be hard to come by, by and large. But hospitalizations would be a big number to look at, too, from a statistics point of view, and that shouldn't be affected by testing percentages.
Thank you, Dr. Connor. Are there other questions? Catherine, do you have something?
I'd like for him to comment on the antibody tests and its use going forward.
Yeah. So just to kind of set the landscape a little bit, how we test currently, this is a PCR testing. So we're picking up not the DNA, but the RNA, it's very similar, of this virus, and we're picking that up in the nose. So this test tells us active acute infection, so something that's occurring right now. There's an antigen test that is down the pipeline that's definitely not been talked about a lot. That would be detecting the proteins of the virus in someone's nose. That would also be pretty similar to the PCR. That would be something that you would check for when you are suspicious someone actively has the infection. The antibody test has been something that's been slowly emerging, and that really tests has this individual seen the SARS-CoV-2 virus before, and have they developed antibodies to it. Clinically, at least in the acute setting or the hospitalized setting, the antibody testing is probably not of a big significance, because we really want to know who actively has disease and how we should protect the healthcare providers and other patients from that individual. I think antibody testing as an outpatient in the community to kind of better assess maybe a herd immunity, to know the epidemiologic pattern of this disease and how it's affected our community, to know the percent of individuals who are antibody positive at a certain period of time. I think that'll be interesting. I think that'll be helpful in predicting how this virus could spread in our community, how it might continue to spread, and is there sort of an end in sight before the vaccine? So I think that's helpful. The other thing to think about too with the antibody testing is if an individual does have antibodies to this virus, are those antibodies going to confer protection for that individual? So that has not been, we assume antibodies should protect us, but my question would be, at what certain levels of antibodies in the blood does it offer protection? So I worry about maybe a false sense of security if someone does test positive for the antibody and thinking that they don't need to wear a mask or they don't think they'll be affected by the virus, again, I would caution them because there's really not a lot of studies out there that would support a certain number being protective, or there's a lot of unknowns. And so I think it would be good to know a snapshot of our community and who's been infected or what percentage. But I think there could be a lot of false sense of security in some folks, and that may lack some of the social distancing, which may lead to another resurgence. So it's definitely something in our armamentarium, I think, against this virus, but it's something that we really need to be really understand a little more completely.
Thank you, Dr. Connor. Good question, Catherine. Any other questions from the floor?
Can you hear me?
Yes, sir. Dr. Richmond.
How strong is the evidence that the virus emanated from bats as opposed to a Chinese laboratory? Can we confidently debunk that theory?
Yeah, there's a lot of molecular genetics that people look into on similarity in coronaviruses. There's 4 that circulate in humans commonly. There's a bunch of other ones too. A lot of mammalian species also have coronaviruses, including bats, some pangolins. Basically almost all mammals seem to have this. And so there's some genetic sort of timelines you can put together and similarities you can piece together in the codes to kind of see where it may have jumped. I think a lot of the data is from bats. There is that virology clinic in Wuhan, but I think they're a pretty well respected virology lab, and they do a lot of studying about coronaviruses and other viruses. So they probably did have a bank of coronaviruses that they've investigated and looked into, but they're just doing good science and trying to study this virus and get a better understanding of it. But I think the best data is that it was in sort of close proximity in some of these markets, and these viruses are very bad at replicating themselves, and there's a lot of errors, and some of those errors can cause it to jump species. And so I think that's probably the most common, especially when we're talking about zoonotic diseases, so diseases in other animals. The closer your proximity to these animals, the more time you spend with them, the more opportunity a virus has to jump. And we see that in the flu too. Bird flu, swine flu. It's very similar. The viruses are made up of similar RNA, and they're bad at replicating themselves, and so they are able to make a lot of mutants that may be more deadly or more suited to a human host. And so we do see this commonly in other viruses as well, as the jumping species recombinating itself with another strain and having a different pathogenicity or another host that it might be better suited for. So, and then it just takes off when it gets that opportunity.
Thank you.
Other questions before we close it out? Dr. Connor, let me say again that we're incredibly blessed to have you in our community. Thank you not only for being here, for taking care of the patients in our community, our friends and neighbors, but also being with us today as part of the Rotary Club. This is certainly a service to us for you to take time out of your busy schedule. We appreciate it, and we will pass on the information to hopefully keep everybody safe and well as we go out about our daily business, and not to forget that masks are an important part of that. And so we'll continue to be cautious and the normal safety things that we should be doing, such as washing hands and that sort of thing. So thank you again. I'm going to open it up one more time just to see if there's any other last minute questions. All right.
Well, I would like to say thanks, Amanda. Thanks to you, and thanks, Dr. Connor. We hope to see him in the club and give us a talk when we are able to meet together, not as a doctor patient, hopefully not.
Yeah, no. Well, thank you so much for having me. It's been a real pleasure to talk with everybody. And if there's any other questions, please reach out. We'll be able to get you any information. I know things kind of pop into your brain afterwards. At least they do for me.
Thank you, Dr. Connor. I'm going to do a screen share. We normally close out our meeting with the Pledge of Allegiance and the four-way test. Certainly, we want to make sure that at least we have it on the screen today. For those of you, obviously everyone knows our Pledge of Allegiance, and so we want to honor our nation and our flag with that. And then also with the Rotary four-way test. For those that may have joined us as a guest, we have a four-way test in Rotary that we always like to acknowledge and make sure that we live our life by. So both of those are on the screen. Since we're in a bit of a different format, we won't do that today, but I do want to say thank you again, Dr. Connor. Again, for the folks that are on the phone, we'll continue to try to find ways to connect. Again, thank you to the amazing board that we have this year. Thank you for the time that you've spent trying to make sure that you serve your fellow members and also the community. So thank you for that. Also, we will honor our fifth graders for their service above self. The Charlie Bowen fifth grade awards will go on this year, and we'll do a Facebook watch party so that those children and those parents and teachers will be able to honor those students. And for those of you that want to share pictures of either what you're doing in your free time, or as Dr. Venable pointed out, those that don't have free time, what you're doing and look like as business as usual, we do want to connect with one another. Rotarians, it's an important time for us. It's important to make sure that we are serving one another, that we are serving our community. So please continue to do the good work that you do, Rotarians at Work, and we'll continue to meet in this new normal and world that we're in. And I look forward to the months ahead as Ricky Robertson, who is a fantastic guy and fantastic Rotarian, takes us forward into the new presidential year. So more to come. Again, Dr. Connor, thank you. Sandy, thank you for organizing, as well as Kim Reynolds, who helped organize this meeting and making sure that we were able to talk to Dr. Connor. If there aren't any questions, I'll pause for just a few seconds or minutes before we turn it over, and I'll adjourn. All right. Thanks, everybody.
Yeah.
Happy Tuesday. Bye.
Bye-bye.
Bye.
Bye.
Thank you.